comenzamos esta mesa redonda. Tendremos a dos ponentes en esta mesa. En primer lugar, contamos con Jill Litt. Well, she's a doctor and a professor at the University of Colorado. She's a senior researcher at the for Global Health, ISGlobal. She has a PhD in environmental health and public policy. Her extensive research encompasses community gardens, urban farms, and nature-based social prescribing. So, well, we are going to do the question after each presentation. You can do them in English, in Catalá, in Castellano. We So thank you, Jill, and you can start when you want.
Hi, good morning. Buenos dias, buen día. So I'm Jill Litt. I'm really happy to be here. First, I just want to acknowledge the UBIC team. It has been amazing to get to know you. I feel privileged to be a part of this day, and also to meet all the colleagues and scholars working really hard at this intersection of loneliness and social health and older adults. Did I say it right? So I come as an urban health scholar. I work in environmental epidemiology. I've been an environmental epidemiologist, and I've worked really across the lifespan. And the projects that I've been working on in Europe since I've been here, I came in 2016. I had a Marie Curie. Then we got a Horizon Europe project, so I haven't gone home yet. But my base institution is waiting patiently for my return someday soon. So the project that I've been most interested in right now is working on this loneliness project using nature-based social prescribing. But today I'm on a strict, tight lane to not talk about recetas, but happy to answer questions afterward. But really to talk about the different models of social prescribing and, first obviously define it because not everybody here knows what this is. And then I will give a couple examples that might point to the recetas project, if that's okay. I do want to just acknowledge the author. So today's presentation really comes out of a collaborative effort that several of the recetas researchers put together. So Dr. Laura Coiplanas, M₃O, Ashby Sachs, who I think is on the call, and Dr. Michelle Howarth. And then also I want to acknowledge Laura Hidalgo for the creative contributions to this paper. So all the artwork came from Laura. Here's a citation for the paper if you're interested. It is actually not open access, so we can just talk afterwards to figure out a way to get that information. And also a shout out to our funders, the European Commission, Horizon 2020 Research and Innovation Program. This is the grant agreement 945095. These are all of our partners that have come together to make recetas what it is today, and I'm eternally grateful for everyone who's contributing through this initiative. And then, of course, we have all of our kind of cousins and sisters and family projects that are related to recetas. So it's been really amazing to, at least in Catalonia, have this opportunity to connect our project with all of these ongoing initiatives. So I will just hit a couple highlights for today's presentation. First, just to give a definition of social prescribing and talk about the different models. And this is really important because I think in the earlier talks, just thinking about how do we intervene on loneliness really depends on context, on the social structures, the capacity at the local level, how people relate to this topic, the severity of the condition. So we need to be agile in how we approach this issue. And there are different models depending on where you come from and your country's readiness for it. So most of what we know about social prescribing stems from the United Kingdom. But of course, other countries are interested in this. So we're going to talk about, this is kind of what prompted this paper, was really thinking about the different ways in which we approach social prescribing. Then some trends in social prescribing activities. Also looking at the movement of social prescribing. So it's no longer just the UK. The rest of the world has woken up and said, we want this too, but how do we do it? And what does it look like? And how can we get started? So I'll talk a little bit about that movement and then some key recommendations. So this is one of the first pieces of artwork from Lauda that helped us kind of think about this trajectory and how we have seen the movement of social prescribing evolve since the 90s. I'm sure it's been around before without calling it social prescription, but it is something where it was sort of, what is this thing, and defining it and developing the elements of it, and then really organizing these models and starting to generate evidence. And I feel like we've been in that space for a very long time. And now we're sort of moving into this upward tick of thinking about what is the impact and how to quantify it, qualify it, and use a whole range of methodologies to do that. And now this other phase that's happening is this movement across borders where many, many countries across the globe are thinking, how do we start to use this as part of our health solution to address a whole myriad of issues, not just loneliness. So at a really basic level, and this came out of an exercise led by M₃O to really think about, like, how do people define it, interviewing and engaging professionals and academics. And the definition that came out of this consensus process was that social prescribing is a holistic, person-centered, and community-based approach to health and well-being that bridges the gap between clinical and non-clinical supports and services. In our work, sometimes we refer to as a non-medical community referral. So it still could originate out of a health system, but it's tapping into the activities and resources available in our community. And it leans on techniques like motivational interviewing to really work with a patient from the bottom up to figure out what are the root causes of why people are not feeling well. So it tries to get in on the things that really make a difference in someone's life, which changes their course. And it may not require pharmaceutical intervention after all, but only until we start approaching health through this very holistic lens. And this is what social prescribing allows us to do. It's very hard to have sustainable treatments and really focus on prevention and health promotion. So this is a really important tool in theory, and there's a lot of enthusiasm about it. But as I'll show later, the evidence is pretty thin, even though there's hundreds and hundreds of evaluations. They tend to sort of follow the same forms, and maybe we're not really, first of all, we're missing the blind spots. So we have to be critical about how this works. And then we need more robust studies. So that's what we'll get to later on. And the pictures, I think I've got most of the photo credits. This comes out of our team in Cuenca, and also doing one of the case studies. Again, I'm not going to talk about recetas, although I will. And just a beautiful project coming out of South America. So this is the schematic that we put together, and this really is building on other papers and other scholars who have looked at the different models of social prescribing. But it sort of is a continuum, and each element, it's not really exclusive to that one lane, if you will, of model 1, model 2. There's elements in each of these models that sort of remind you or reminiscent of another model. But there is this sort of scheme. The schematic is that you can go from sort of here's a list of resources to a patient showing up saying that they're feeling blue or they're feeling this, and maybe they want to lose weight, and they get a list of resources in the community and they sort of refer to it as signposting, but there's very little support once that person leaves the office. But this is an important gateway, if you will, to this concept of social prescribing. Then you move along this continuum where you might have, and every stage is a little bit more support. So at the model 2, now you have a little bit more consultation, a little bit more discussion about how to activate these activities, but you're still really on your own. You don't have the social support following you through this process. Then model 3 and 4 introduce this notion of a link worker. This is very centric to the United Kingdom and the model that is most prevalent there, where you have a link worker now working with providers and the patients. And now they're incorporating things like motivational interviewing, where they're asking people about the things that motivate them. What do they love to do? What are the things that are most pressing in their lives? Like, it's taking a social determinants of health framework, and it's looking at these root causes. Once you start to figure out what people love, maybe it's art, maybe it's music, maybe it's spending time with friends, then this program and this link worker helps connect these people to these services. If you go further into model 4, this is a more holistic approach, but now there's follow-up. Maybe there's more than one contact. Maybe it's up to 5 contacts that a link worker will have with a patient. And this also is supported by the National Health Service. So this is what's so exciting is when the health service can get behind, or health insurance can get behind this kind of intervention. Again, a little bit of faith, some data, but maybe not the most robust study. So we still don't know if we believe this is working, but we need to continue to develop how this is working. And then the fifth model, which is where Recetas comes in, and other entities elsewhere, but really like a Circle of Friends in Helsinki, I think may not call themselves a social prescribing program, but essentially the idea is that people get referred to a group because we know that social organization is really key to getting to health behavior change, to health improvements. So it's the activity. It also hits the list of ingredients that we heard about before, which we very much hold at the center of all of our work, is that there's direct participation, there's intergenerational connection, there's a social organization. For our work, we feel like we want it to happen outdoors in nature. So we feel like nature is an amplifier. And so we want to bring that into our ingredients for what makes a good program. But essentially, in these instances, the other piece that's unique to this fifth model is it's a curriculum over a period of time. And in our case, it's around 9 to 10 weeks. But that we're evaluating what is the crucial time we need in this kind of model. But the idea would be that if this is effective, then this becomes an option for health systems, for physicians and care providers to refer people to a facilitator. So again, we have that liaison. And when you ask Julia about what's important, having that facilitator to link with the service in the community and going through that process to see what people like to do, then you have like a matchmaker in some way. And there's a bit more context and social support to help someone engage in an activity that might be new. It's not that they can't take it on. It's just that the way you kind of introduce people to it, this is where this becomes very powerful. So I think I've pretty much described these models just with the figure alone. So I think I won't repeat this, but maybe the slides will be available later, for participants. And I just mentioned this, that one of the key things is that these link workers and facilitators, why this can be so powerful theoretically, so this is theory informed, is that you're tapping into the emotional, social, and health needs of a patient. And when you can get at that very fundamental level, you start to open up the possibilities to make suggestions and referrals to things that might make a difference in their lives. And again, hitting so many different outcomes. So we've only sort of scratched the surface and focused on loneliness in our own research. But in my community gardens research, we see this play out, and it's hitting on diet and physical activity, stress, anxiety. We've seen these interventions move the needle. So now we're just scaling it up to think about how else can these kinds of mechanisms support health behavior and health status. So I'm going to just keep going through because we kind of covered these ideas. And I'll talk a little bit, and this is where we might have some overlap, won't say, but I'm sorry about that. So nature-based social prescribing is a variation of this. So there could be arts and prescription you've probably heard about, exercise prescriptions, food garden prescriptions. So people are liking this idea that there are these referrals to community resources. For us, is an umbrella idea about nature-based social prescribing. So it's following the pattern of social prescribing, but it's leveraging nature and connection to support health and well-being. In nature-based social prescribing, if I go through these different models, so model one, the signposting, so this happens. So in the US, for example, there are a number of examples where, like, for example, the Children's Hospital of Colorado screens young moms or pregnant and parenting teens for loneliness and social determinants of health. If these patients are screened positively, then they're handed like a list of resources in their community, and some of it's nature-based, some of it's more about music and art and so forth. But there's no follow-up. There's no system to track their participation. There's really no way to know, but they have handed these opportunities because they recognize that perhaps the solutions might be in the community. In the direct referral, then again, it's collaborating with participants. It's maybe incorporating some other kinds of ways to find out what people like to do and helping them find the things that match their interests and motivations. In model 3 and 4, this is where we have the link workers. It's more holistic, and it's working with them and connecting to these third sector organizations to help people find these activities, but it's individually based. So it might be, walk in a park 3 days a week. There might be a bit of a prescription on it. Maybe it's even walk with a doc, have time with a doctor. It attracts someone to come in. But again, it's really about the individual showing up. And then in Model 5, this is where the facilitator is involved and we have this curriculum. And so in our case, we are working with people trying to connect in the nature-based activities, but they don't have to do it alone. So they can be outdoors together with others. And so we feel, again, here, this is building on theory that shows that social involvement, social connection, and nature contact or aesthetic engagement, these are the amplifiers. These are the things that really ignite and light up people's openness to hearing, learning, thinking, all kinds of things. And it's a safe place. It's anonymous in some way because you're out there in nature. And then, so this isn't just, we think it's a good idea. It's really data-driven. And now we're applying it in this 10-week curriculum. So this kind of fits under this fifth model. And I just want to give an example of, this is this idea of a menu. So in the Reset This approach, we've used co-creation to create these menus. But sometimes in clinic settings, like in the example from the Children's Hospital in Colorado, there wasn't really necessarily this process of co-creation, but it was this effort to create like a list of opportunities. But in this regard, we recognize nature isn't for everyone and every community is different. And there may be costs and other barriers. So we used a very detailed co-creation process developed by our colleagues in Cuenca to begin to allow third sector providers, researchers, and community folks to come together and figure out what is meaningful for them in their community related to the everyday experiences that they have. Now, in the Model 1, we will hand this out. People will have access to this menu. And then go through the continuum. You might have health providers handing this out, discussing it with individuals, but there really isn't follow-up. But in the fifth model, which is the Reset This model, we refer people to a group and then they go through these menus, they pick their activities, and they design their curriculum basically for 10 weeks. So that's kind of the goals. Now, every site implementation, you'll hear about it later, is going to look a little different, but that's kind of our theory. So just to kind of start to bring this back in. So you have the models, you have a feeling for what this could look like. There's been a lot of research on this. So is it working? That's like the big question. And if so, how and for whom? And believe it or not, there have been 11 systematic reviews, 14 realist reviews trying to understand what's happening in social prescribing. And now there's reviews of reviews. So this is really like we're delving into this data, trying to make sense of it. But what we have seen are some patterns. One is that most of the studies are qualitative and observational. There are several controlled before and after studies, but there's even fewer randomized controlled trials, which would be the gold standard, where you have a comparator, there's randomization. This is what in epidemiology we hope for and strive for, although it's very difficult in the community to do that. So you really need strong connections with your organizations, community folks, a lot of trust to be able to do something like this and randomize. And you can imagine that not everybody's going to be happy about the outcome of a randomization. So this is the real social reality of doing this kind of research for something like a social prescription, where most people want it. They don't want to wait. And we've tried this in a gardens community trial where we randomized people to a garden plot for a season and those to wait. We actually had great compliance. But in the US, we have different incentive structures. And so we can make it sort of worth their wait, and then we found very good uptake following that season of gardening. Anyway, but without those kinds of studies, we're guessing a little bit. And also that the samples are smaller. And so it's just hard to make these generalizations about the effectiveness. And the other piece we're lacking in some ways is the economic data. Like, is this making an impact economically? So the general consensus is that we're still lacking a clear understanding of effectiveness of social prescribing, and then that's difficult because it's hard to justify policy and practice without that evidence. There's also consensus that we need these comprehensive evaluation frameworks. So that the qualitative is great, the observations are great, but we just need to continue to make this more robust. And that it should be participatory in the way we design these evaluations and should happen at the very beginning of the study, so that this isn't sort of an add-on afterwards, but that it's from the beginning. I talked about this kind of global expansion, and actually every time we sat down to write, there was more and more evidence that another social prescribing program had started. So it was in the 20s. In 2022, I think we documented Daniel Morse and his team. Then in 23, there was a really nice evaluation of global social prescribing. That was a partnership with Global Social Prescribing Alliance, the National Academy of Social Prescribing, and the World Health Organization, led by Khan and others. By the time we wrote, we had identified kind of 33 nations. So it was up already just in a year or two. Just every day was something new. And there's probably more. I found that going through social media and trying as many languages as possible started to uncover more and more programs in other countries. So we're missing it in the literature and even websites. So really just seeing what people are posting about in social media was helpful in sort of finding our way across the globe. And the little green position points are the Rosetta sites, where we're also testing this Model 5 that I've spoken about. So we're in Cuenca, Ecuador, and then 4 countries in Europe, in the Czech Republic, Finland, Spain, and France, and then in Melbourne, Australia. So that's just kind of restating that. The main focus of our work is on loneliness and health-related quality of life. We are using randomized controlled trials in 3 of our communities and pre-post studies in the other communities. How am I doing on time? Okay, over? Okay. I'm happy to talk about this later, but it just kind of shows the mechanism of action, like how do we think this is going to work? And this kind of very much is complementary to what we heard this morning. But the idea being that these interventions are designed. So the important thing is you can intervene on these things. I think there is this feeling that maybe we can't intervene on aesthetics and we can't intervene on social relationships and making friends. But the evidence really has shown that we can. So this intervention is is intentional to intervene on these things. We hope that by participating in these groups over time with a trained facilitator, one is that it becomes autonomous, that they start to take control. But 2 is that we foster this ability to share experiences. 3, with it, that we create these feelings of togetherness. We foster peer support, and we foster making friends. And when those things start to come together, we have this more profound sense of social connectedness. And then that will put us on the path to these other kind of health changes that we're looking for. Final slide, almost final. So social prescribing provides this agile solution. It can be adapted culturally, geographically, economically, environmentally. So that's the beauty of it, is that it really can fit the local context. We should continue to work and strengthen the evidence base. It's important to have a behavioral science approach in these kinds of interventions, and that it's theory-driven, and that our evaluations should focus on the outcomes and the processes. From a policy perspective, I think the multi-sectoral partnerships are crucial. Funding to support this type of work and also the evaluation is needed. And importantly, that we support the third sector organizations who are helping. So a lot of times this is an unfunded mandate, and it's nice for a little pilot, but if you really want to sustain change, reimbursement needs to go to our organizations helping make this happen. And then I finally just a bunch of the papers that I cited. Here are the references in case you want to follow up, and some ways in which you can follow the Rosetas project, or contact me if you would like any more information. So thanks so much.
Okay, any question here or in the chat? Julia, any question in the chat or here in the room? Okay, what is the micro, or if you want, you can do it. Yeah, maybe it's better, yeah.
Thank you for this great presentation. I think you point at a critical issue about how to assess social prescribing, and you mentioned the gold standard of randomized control. So epidemiology, and how epidemiology is normally, what kind of methods epidemiology use in order to assess if something is working or not. And I would like to know more about this, and because it seems like you're entering into a new field, which is social relationships, which is the field of social sciences. And I was wondering about if interdisciplinarity comes into play, especially in order to maybe envisage different ways of assessing effectiveness, impact, and things like that. So I want to know more about this challenging thing.
Wait, and I didn't quite understand what did you say comes into play? What was the?
I mean, the idea of, okay, this is, you mentioned like you can intervene in social relationships, and then you can assess your interventions. It's something that seems that is growing, and you are encouraging people to do so, but I see that it's something that social relationships that are more maybe complex, or their subjective dimensions, things like that. So it's more challenging to assess these kind of things with the methods normally public health use. So I was wondering more about this.
So I'll maybe just do really brief, and then maybe there's room for discussion later in the day to kind of get into the trials. But in this case, you know, so first of all, we're building on Circle of Friends, which was a model developed out of Helsinki in Finland. And the whole idea is supporting people to build friendships and to build trust between each other. And then we've taken that into this kind of 9-week approach where every week there's intention about how to form relationships, how to build trust. And at the end of it, in our case, we're interested in alleviating loneliness, reducing the levels reported, but also improving health-related quality of life. So those are our primary outcomes. But we also have this very detailed questionnaire, maybe too detailed, on all of these social constructs. So at the basic level, the randomized control trial, we would evaluate, was the intervention as a whole effective in reducing these two primary outcomes? But then in the secondary analyses or post hoc, you know, where we have secondary outcomes, we'll start to look at how. We'll look at the mechanisms. Okay, so there's the quantitative piece of that. And that's where a lot of people are really concerned, and they want to see the p-values. They want to know this is having impact. But I think what gets us all excited are looking at those intervening mechanisms, also the qualitative data. So I'm not saying it shouldn't be a part of it at all. It's so rich. And that's where we're going to really know people's story and experience in the intervention. And then I think together, when we have the stories and the statistics, we will be able to say something really profound about how this mechanism, how this intervention works. So it is possible. I think the thing that gets tricky in the randomized control trials, again, is what's the randomization? What's the control? Do people have access to the intervention afterward? So there's kind of the equity issues in these trials. It's messy, it's community, all things come up, it's life, you know, so it's hard to hold that population that you recruit. But you can do it again with the right support, the right teams, encouraging people to keep going without too much contact because you don't want to change the intervention. So, you know, there's all these questions we have, like literally every week, you know, about how to manage this process. And then helping our data collectors, because they're very much a part of these people's lives. So how to set boundaries and make sure that actually our staff are safe as well as participants. So because sometimes, again, in these kinds of trials where we're dealing with people who, not dealing, but we have people who are hurting, they're suffering, how much support we can provide as a trial and our staff versus how to make sure we have the right supports in place if something else comes up. So it's complicated. And I would say I don't know if it's harder than a large pharmaceutical trial, but for sure we have all kinds of things that come up that you could never imagine in a very well-controlled clinical study. So I don't know if that's helping get closer, but you know, and the other piece I would say is that when we started, we had this conceptual map of how we thought this was going to work, and we've really stuck with it. So, you know, figuring out the mechanisms and exactly which outcomes we want to focus on and measure, and what can we measure. And
Okay, thank you. Well, as we have, no, it's okay, Jill, it's okay. I wanted to say that as you suppose this module of the conference is based on social interventions in health, because I didn't say it before because we have we have few times. So, but I wanted to ask you something, Jill, because based on your knowledge and your experience, and the experience that there are in some primary cares here in Catalonia, what is the future of social prescribing here in Catalonian health system, and what is necessary to apply it in the future?
Well, I think the future is very bright, and I'm looking at Cristina Casajuana because she's a very senior person in the government who is a partner on our grant. And I would say there has been incredible cooperation with the Catalan Health Department, the Barcelona Health Department, sister health departments like in Vic, the CAPS. I feel we have had incredible reception to this, and it's already going on. We're just testing a different approach. So I think the feeling is together, we are going to be able to piece together a really nice portfolio of options if a clinic decides to go in this direction, because it's not mandatory, I don't think. It's just voluntary at this point, because you really need providers to be interested and engaged. So it feels very optimistic here. And then word on the street, like from our colleagues in France, is that it's actually starting to change. And there is this renewed, or not, a new interest in social prescribing. So even when we started, it wasn't there. It was a lot of conflict about how to move forward with this project. And now there just seems to be reception to it. So in Barcelona, it feels very hopeful. And then I would say in our cities across the globe, people are waking up to this. And I think this evidence is going to be crucial to move it forward. If we're successful, and if we're not, hopefully we have a lot of insights to figure out how to make it successful.
Okay, thank you very much, Jill.